This lecture is going to cover some of the aspects of the mediastinal divisions, so we're going to review that, and then we'll move into going through a number of different scans to look at examples of structures that we've already discussed thus far. So remember that the mediastina are broken down into multiple different divisions. So we have the superior mediastinum located just above the transthoracic plane, and then we also have in the inferior mediastinum that's broken up into anterior, middle, and posterior mediastinum, with the middle mediastinum containing the heart. So anterior to that, you have just sort of a small space where the thymus is located developmentally, and then posteriorly you have a number of great vessels and other structures located in the posterior mediastinum. And so remember that the posterior mediastinum is going to end at the costodiaphragmatic recesses, which again you can appreciate right here and right here. So looking at a schematic, we can see again the transthoracic plane right here, and then we have superior mediastinum just above that, inferior mediastinum below the plane, with the anterior, middle, and posterior mediastina comprising the three components of the inferior mediastinum. And so here you can see the hemidiaphragm looping up and over, where the heart is sitting on top of that. And then again, you can see the costodiaphragmatic recess located down here. So looking at this on imaging, so again, the transverse thoracic plane, which is represented by this horizontal line, is located at the sternal angle, so the T4-5 vertebral level, so where the intervertebral disc is located between T4 and T5 is the approximate level of the transverse thoracic plane. And then these two lines coming down here are representing the anterior mediastinum, the middle mediastinum, and the posterior mediastinum back here, where you can clearly see the thoracic vertebrae. And then in the middle mediastinum, you can clearly make out the silhouette of the heart. So there's a couple of spaces that you want to be familiar with related to these mediastina. So first off, the retrosternal space, which we mentioned previously, so that should have this sort of darker appearance to it, just superior and anterior to the location of the heart, or the heart silhouette, which again you can appreciate right there. The retrotracheal space, which is circled right here, so it's going to be located just posterior to the trachea, so you can see the trachea coming down right here, and then branching into the right and the left main stem bronchi. And then finally down here in this other darkened space, you have the retrocardiac space. So if any one of those is not a typical dark appearance like this, you should be considering that there's something abnormal with that scan. Another thing to keep in mind is we talked before about the lung fissures. So remember that you have the horizontal fissure on the right, as well as the oblique fissure on both the right and the left lungs. And so what you want to keep in mind with the fissures is that they're not straight lines. They have sort of this arched appearance to them. And so you can see how they kind of come down like this. And then the dotted line here represents the fissure of the contralateral lung. So you're looking at the right lung here, so this dotted line represents the oblique fissure in the left lung. And then simultaneously on this side, where you're looking at the left lung, you can see that this is the oblique fissure, so left upper lung, left lower lung. And then this is going to represent, this dotted line represents the oblique fissure of the right lung. And so you'll notice that it forms this propeller-like configuration of the fissures when you're looking at them on imaging. I would argue that it takes a very specific image to be able to appreciate this well, but it is something that you can certainly see on imaging. And so this is an example where you can see both the left oblique fissure, and here's the right oblique fissure located right here. Again, it's hard in this image to get a good appreciation of the propeller-like appearance, but again, you can kind of get a sense of at least what the major fissures look like in some images. Remember, in some patients, you can't see the major fissures at all. So now looking at another lateral view, this is a list of all of the major structures that you can appreciate on a lateral chest x-ray. So we've talked about some of the spaces, the retrosternal, retrotracheal, and retrocardiac, but now we want to make sure that you're familiar with the major structures located throughout the lateral view. So we'll go through these one at a time. So first off, the trachea, which is circled here in yellow. So remember that just posterior to that, you have the retrotracheal space. The tracheal stripe, that just represents the posterior border of the trachea. So you'll see that kind of looks like a line on a lateral chest x-ray. And then you also have the retrotracheal space, again highlighted here in yellow. And then finally, the scapula usually is going to be located just posterior to that retrotracheal space when the arms are in horizontal position out in front of the patient. So that's the typical orientation that we use when we perform a left lateral or any lateral chest x-ray. So at the center here, you're looking at the hilum of the lungs. Again, look for that dark eye right in the middle. That's going to represent the left main bronchus. And then the right pulmonary artery is going to be located just anterior to that. So again, you can kind of make that out right here is the right pulmonary artery. And then the curved opacity that you see just above it, that's going to be the left pulmonary artery branching over or arching over the left main stem bronchus. So here we'll highlight each one of these. So first off, again, this is the right pulmonary artery. Then we have the right main stem bronchus. So again, you can make out how it's just kind of a little bit darker through this region. So that's where you're looking at the right main stem bronchus. And then in cross section, you'll eventually see the left main bronchus here show up in a moment. And then arching over the left main stem bronchus, we have the left pulmonary artery. And then finally, that blue dot there represents the left main stem bronchus, which is going to appear the darkest right in the central region of the hilum. So the silhouette sign is something that's important to be aware of. This is a sign that's used to identify pathological changes in chest x-rays. And so the idea here is that if you know what structures should be adjacent to each other, if you don't see them adjacent to each other, that tells you that there's a pathological process going on or something else that you need to investigate on the scan. So the right diaphragm is located adjacent to the right lower lobe of the right lower lobe on the right lung. So I'm just going to call that right lower lobe. And then the right heart border is going to be located right, so that's going to be the right atrium, is going to be located right next to the right middle lobe. The ascending aorta then is located right next to the right upper lobe. Similarly, the aortic knob, which we'll see here momentarily, is going to be located next to, that's part of the arch of the aorta. That's going to be located next to or adjacent to the left upper lobe. The left heart border, which represents the left ventricle, is going to be located next to the lingula. The descending aorta is located next to the left lower lobe, and then the diaphragm, the left diaphragm, is also located next to the left lower lobe. So again, if any of these adjacent structures aren't easily appreciable or appreciated, that indicates that there's probably some pathological process or positioning issue that has occurred in that patient. So here we can see the aortic knob right here. So you can see that located right next to the left upper lobe. That means the right upper lobe is going to be located right around the same region where we have the ascending aorta. So again, this is all going to be right upper lobe up here. Right middle lobe is going to be located right next to the right border of the heart. So again, this is the right atrium that you see right here. Right lower lobe is going to be located adjacent to the right hemidiaphragm. Left lower lobe adjacent to the left hemidiaphragm. And then we have the lingula, which is going to be located along the lingular lobe. So the lingula, though, in any event of the left lung, is going to be located next to the left border of the heart, and then again left lower lobe located along the base of the heart as well. Here's another image showing basically the same thing. So what I like about this image is you can see the the aortic knob quite well right here. So remember, that's going to be the location of the left upper lobe. Right upper lobe then is going to be located in approximately the same location. Down here where you can see the right atrium, that's the approximate location of the right middle lobe. And then the lingula, remember, that's going to be located approximately at the level of the left ventricle, so the left border of the heart right here. And then right lower lobe, and left lower lobe down here, adjacent to the right and left hemidiaphragm, respectively. So in this patient, this is a scouting image that was taken before a CT scan was performed, but it allows you to be able to appreciate some of the structures that we've talked about thus far. So again, you can see a very prominent aortic knob located right there, and then obviously the left border of the heart right here, so it's going to be located next to the lingula. Left lower lobe down here. Notice the angulation here on the costodiaphragmatic recess. So there is actually an abnormality in the scan, and so over here you see that on the right side. Notice that there's this costodiaphragmatic recess on the right side is blunted. So when you get blunting of one of the costodiaphragmatic recesses, that indicates a likely pleural effusion. So usually fluid is accumulated in that recess and has caused blunting of it, so you don't get this nice sharp appearance of it that's as deep when you have that fluid filling that space. And this individual, again, I'm going to take the overlay off just for a moment just so that you can appreciate it, but you can see where the trachea is coming down here, so you can see it make out the outline there. And so the right and left tracheal stripes can be appreciated in close proximity to the head of the left and right clavicles. And then you can see that obviously the spinous processes as you descend along the thoracic spine. And then as you follow the trachea down, eventually you'll see the carina, and then you see the branching of the left main stem bronchus. You can see that kind of outlined right through here. And this is the left main stem bronchus, and then the right main stem bronchus located right through here. And so if we put the overlay on top of that, again, you can see the basic orientation. Remember, the right main stem bronchus is going to be more vertical than the left, and so typically foreign bodies are going to lodge in that right main stem bronchus, and we'll look at that a little bit later. And then you'll notice the arch of the aorta. So again, that's forming this aortic knob that you see right here, and that's going to be in close proximity to the AP window that's in relationship to the left pulmonary artery. And so here you see the orientation of the heart. So remember, the apex is down here, oriented in the left lower aspect of the left hemithorax. You can see obviously the right atrium forming the right border of the heart. So again, if I take this overlay away, you can see down here again that right border. So this is all going to be right atrium located right there. And then we also have obviously left ventricle. You can see just on the lateral border of the heart, just this small little region right here. And so the majority of the anterior surface of the heart that you're seeing on a PA or an AP X-ray is going to be the right ventricle. And then obviously the aorta coming up and over off of that, pulmonary trunk branching off and giving off the right and left pulmonary arteries, and the pulmonary veins right below that. So here's that costodiaphragmatic recess, or the costophrenic sulci. So again, this is going to be where fluid typically will accumulate in the pleural cavity. So that's why you get that blunting of the costodiaphragmatic recess with a pleural effusion. And so that's what we saw over here on this image that we just talked about a moment ago. So usually the pleural space will only contain about 2 to 5 mils of fluid, but about 300 mils of fluid will cause blunting on a PA chest x-ray and 75 mils on a lateral chest x-ray. So the lateral chest x-ray is going to be more sensitive for picking up a pleural effusion in this case, because again, it takes less fluid for it to be clearly observable on a lateral chest x-ray versus about almost 4 times as much fluid to be able to appreciate that on a PA view. So here, looking at this image, I want to give you a second to look at it and see if you can identify what the abnormality is. So on this one, again, you kind of want to have your standard view. Look at the skeleton, look at the mediastinum, look at the soft tissues, etc., and look for the lung markings, so you can see all the pulmonary vasculature quite clearly. But notice up here where you see this kind of half moon shape situation right there. So you can see that this is going to be what we call a pneumothorax. So that's where you get air into the lung or into the pleural cavity, and eventually that's going to lead to atelectasis or a collapsed lung as a result. And so again, you can clearly see here that we have a small pneumothorax. And so the line that you're seeing right here is actually the visceral pleural line. And again, zooming in on that, you can see very clearly outlined right there the visceral pleural line. But you have to be careful when you're looking at these sorts of images to make sure that you're not looking at what's called a rib companion shadows. That's what we're seeing here in both of these two images are rib companion shadows. So those can be easily confused with the pleural line, but you should be able to see a difference where, notice how much darker it is on the other side of the visceral pleural line when you have a pneumothorax versus the shadowing around in close proximity to a rib. That's where you can make that distinction. All right, so once again, we have another image here looking for what the problem is. So again, hopefully you're noticing the asymmetry in the lungs in this case. So you can see a clear collapsed lung. So this is going to be a tension pneumothorax. So effectively what happens is there's a one-way valve that is causing an air leak. So when you breathe in, the lungs are able to bring air in, but then that air can't get back out because the lung is collapsed. And so this is what we call a tension pneumothorax. And so you'll see a couple of things. First off, you'll notice that distally we don't see lung markings. We only see it more medially or more proximally. You'll see the mediastinal shift. So notice how the heart and the other mediastinal contents are shifted towards the left in this case because we have a right-sided tension pneumothorax, and then the diaphragm is also depressed as a result of the increased pressure in the pleural space. So look at another one here. Take a moment to try to see if you can identify the issue. Hopefully, once again, you're just first off in your initial overview, you're noticing the asymmetry. So you see an asymmetry in the lung lines. So you see an absence of the lung lines on this side. So again, that indicates that the lung is not filling the pleural cavity like it normally would. So you can see this collapsed lung right there. And so here we have, again, where a chest tube has been inserted. So this is just confirming the placement of the chest tube. So you can see this is in the same patient. So they're trying to treat this left-sided pneumothorax. And so here's another one to take just a moment to look at this one. And so hopefully in this one, once again, you notice that there's still a pneumothorax, so you can see the absence of lung lines, but hopefully you also picked up on the fact that the mediastinum doesn't look like it normally would. So you'll notice that normally you'd expect the apex of the heart to be over here, but on the left side, but instead it's on the right. You'll also notice that there's a gas bubble right below the right hemidiaphragm, so that this indicates that this person has situs inversus. So that's where all of your internal organs are shifted from their normal side to the contralateral side. So the heart is on the right side of the chest than the left. Same thing with the aorta and all the other viscera, including in the abdomen. So again, the liver's over here on the left, stomach's over here on the right. And so that's what we're looking at right here. So again, this is situs inversus with a pneumothorax on the right side of this individual. Now, a related condition, but somewhat different, is known as dextrocardia. So this is where just the heart is shifted in its position. So it's oriented to the right side of the chest or the thorax instead of the left, but the rest of the abdominal organs are not shifted like you would normally expect. So this usually is seen in about 1 in 12,000 individuals. And so this is another example here of situs inversus, where again you can see the cardiac apex on the right side of the thorax. You also notice the gas bubble underneath the right hemidiaphragm, and then the right-sided descending aorta coming down off of the heart there as well. So that's how you know that this is situs inversus as opposed to just a simple dextrocardia. And so here we have a schematic of what this looks like. So again, you can see with situs inversus, you basically have this mirror image where now the liver's on the left instead of the right, stomach's on the right instead of the left. Basically the left lung is now what the right lung should normally be. Right lung is where the left lung would normally be, and the heart has again shifted its apex from the left to the right. All right, so here's another image to look at for a moment. See if you can figure out what the issue is here. So actually, I'm going to go back here for just a moment. So in this case, you can see obviously the cardiac leads that are attached here. So that's what all these lines are coming off of the patient. They have an NG tube in place, and then you can see right here where they have a endotracheal tube. So they've been intubated, and effectively what's happening is you can clearly see the ventilated right lung, but the left lung doesn't really look quite right. So if we look a little bit closer, so this is just showing you the kind of the outline here. So you can see the red dotted line represents the ET tube, the endotracheal tube. The yellow represents the NG tube, and then the blue outline here represents the trachea with the left main stem and the right main stem bronchi. And so what happened here was the ET tube, the endotracheal tube, was inserted too far. It went past the carina, so this is the carina right here, and ended up in the right main stem bronchus. And so as a result, the patient's right lung was being ventilated, but the left lung was not. So if we go back and look at what this looked like zoomed out, so once again, you can see that ET tube coming down and stuck here in the right main stem bronchus. And then now where the tube has been pulled back just a little bit past that, so it's above the carina, and now you get good ventilation of both the left lung and the right lung in this individual. So this is after the ET tube placement was fixed. So you can see how significant a chest x-ray can be in terms of determining an issue like why the one lung is not able to be ventilated in an intubated patient. Here you can also appreciate the aortic knob quite well right there. In this case, we're looking at a PICC line, so a peripherally inserted central catheter. So you should be able to appreciate the PICC line coming across right here, and and you can see it coming down into the right atrium. So you can see it sitting right here. So this is the right atrium located right there. So again, that's a foreign body that you can probably pick up on relatively quickly just by looking for asymmetry, for obvious things that you don't expect to see in your initial survey of a chest x-ray. So again, you can see that line once again coming across and ending here right about the cavoatrial junction. So again, the PICC line coming in from the patient's left side, and it's coming into the left subclavian and then eventually ending up here at the cavoatrial junction. Here's another example of a central line being placed. So instead of a PICC line, this is a peripherally inserted central line. Now we're looking at a central venous catheter. So this is what we just call a central line. And so you can see it's on the patient's right-hand side, inserted through the internal jugular, so it's an IJ approach. You can also come in through the subclavian, in which case you'd see it coming across this way and then moving down into the right atrium of the heart. But in any case, you can see very clearly this central line coming in to the internal jugular, eventually making its way down to the right brachiocephalic vein and ultimately into the superior vena cava before it finally makes its way into the right atrium of the heart. So now coming back to mediastinal contours, so again, it's very important to make sure that you're really comfortable with the normal mediastinal contours that you expect to see on a chest x-ray. So again, you should be able to make out the superior vena cava on the right side, the right atrium, which again, is always going to be forming the right border of the heart unless there's dextrocardia or situs inversus. You should be able to see the IVC also coming up and dumping into the right atrium there as well. On the left side, you should be looking for the aortic knob, which should, in some patients, is more prominent than others, as well as the AP window, which should have sort of this convex appearance to it. It represents an airspace located in between the arch of the aorta and the left pulmonary artery. So again, you should be able to make out that left pulmonary artery as well, and then the left ventricle forming the left border of the lung. But normally, you're not going to be able to see the left atrium or the left auricle on a typical PA X-ray. So here, once again, we can see the arch of the aorta. So this is part of the arch of the aorta right here. So that's forming the aortic knob. And then you can see the AP window, again, that convexity that you see, or sorry, concavity rather, that you see right there in between the aortic arch and then the left pulmonary artery that you can see coming out right here. So here we have another case where there's a number of foreign bodies, so you want to make sure that you look at that on your initial survey. So we can see, obviously, this is a cardiac pacemaker right here. So you can see the line coming down around here to the right ventricle. So remember, the majority of the anterior surface of the heart that you see on imaging is going to be the right ventricle. You can see a replacement valve that's been inserted here into so it's replacing the pulmonic valve in this case. And then you can see a couple of different cardiac leads on this patient. You can also tell that they've had open heart surgery, where you can see here where the chest has been wired back shut after the procedure. These are also cardiac leads that you see on either side up there. This is actually an infant right here, so you can see they have an immense amount of hardware on them. They have bilateral chest tubes. They've had their chest has been wired shut back again, so you can see these are all staples going down the center of their chest right here. They have an external pacemaker placed on them as well. So a lot of hardware placed on this patient, which makes it really challenging to be able to appreciate the structures of the chest. And then here we have a foreign body. So again, you can obviously tell that there's something asymmetrical about this patient. So right here you see this is actually a foreign body. And what this is the nut, as in a nut and bolt. And so this is in a child that had swallowed it, or they had swallowed it, but they went down the trachea, ended up in the right main stem bronchus, as we would expect. So looking at this one again, just for a moment, you want to be looking to see if you can figure out what anatomy is abnormal on this image. And so once again, hopefully looking at the left side of the heart, you notice that you can't really appreciate the left border and the apex of the heart very well. And so remember the silhouette signs that we talked about before. So along that left border is approximately the level where you should see the lingula of the left lung. And so this is an example of lingular pneumonia.